Hello, my name is Dejan Slavnic, and today I'll be talking about the impact of preoperative online spine education on postoperative length of stay, opioid consumption, and time to ambulation. This is an interim analysis of a quality improvement project. The authors have no conflict of interest to disclose. This is the CME accreditation statement. Preoperative education has been shown to improve outcomes and reduce total episode of care costs. However, in-person preoperative education demonstrated poor compliance and no effect on outcome, and therefore we sought to demonstrate improved compliance and subsequent improved outcomes with online version of spine education. A FADE model was used to develop online spine education module, which was distributed to patients during their preoperative clinic appointment. Then we compared the outcomes of patients who completed the quiz and those who did not complete the quiz. Those included in the study were cervical and lumbar fusion patients who were over 18 years of age and did not have a motor vehicle accident or workers' compensation claim in place. Our primary outcome was inpatient length of stay, and secondary outcomes were postoperative opioid consumption as measured by morphine milligram equivalent, time to ambulation, and patient-reported outcomes such as Neck Disability Index for cervical fusion patients, Oswestry Disability Index for lumbar fusion patients, visual analog pain scales for neck, arm, back, and leg pain, PROMIS, EQ5D, and NAS Patient Satisfaction Index. We then performed a univariate analysis and multivariate linear regression with the use of Bonferroni's correction. Table 1 shows the patient demographics such as age, sex, government insurance, and Charlson Comorbidity Index, as well as perioperative characteristics such as previous spine surgery, spinal region, cervical or lumbar, number of operative levels, single level or multi-level. This table demonstrates a fairly even distribution between the patients who took the quiz and those who did not. Table 2 demonstrates the operative outcomes. Under the cervical fusion group, we can see that the length of stay was shorter for those who took the quiz at 1.5 days versus those who did not take the quiz at 2 days. However, this is not statistically significant with the p-value of 0.177. When looking at the morphine milliequivalents total and morphine milliequivalents 48 hours post-operation use, as well as the time to ambulation, there was no significant difference between the two groups. Under the lumbar fusion group, the length of stay, as well as time to ambulation, had no significant difference between those who took the quiz and those who did not. However, morphine milliequivalents total and morphine milliequivalents 48 hours post-operation demonstrated statistically significant reduction of opioid use in those who took the quiz versus those who did not. Table 3 shows the multivariate regression analysis results, which demonstrate that online preoperative education was strongly associated with reduced morphine milliequivalent use in those patients who underwent lumbar spinal fusion surgery, with the p-value of 0.03. In conclusion, our study demonstrated that the preoperative spine education intervention led to significantly reduced opioid consumption after lumbar fusion surgery. This can potentially be generalized to other surgical procedures as well. And PRO-data was not analyzed in the interim analysis as a significant portion of our cohorts have not reached the follow-up time points yet. Thank you.